Right. Well, good morning and good afternoon, depending on what part of the world you're in. My name is David Hamer. I'm a professor of global health and medicine at Boston University and also the interim director for the Boston University Center for Emerging Infectious Disease Policy and Research. And I'm going to be moderating this symposium on pandemic preparedness. Just, one brief comment. During the last 15 years or thereabouts, we've seen, two pandemics and almost three if we count monkeypox. We had H1N1 in 2009, 2010. We've had COVID over the last few years, caused by SARS-CoV-2. And then we had a fairly widespread monkeypox outbreak. And so we anticipate over the next decade or two with climate change and other factors, increased population density and many other factors, that there will be more outbreaks and potentially more pandemics. So we need to be prepared. And that's really the focus of this discussion this morning. Just a quick outline of what we're going to be doing. We really have two sections. We're going to be having Dr. Matthew Hepburn, who I'll introduce in a minute, from the US government, describe the pandemic preparedness plan that's been developed. And then a panel will basically discuss that, ask questions, comment on the plan. We'll then shift and have a series of presentations by a group that have a recent PNAS publication that also addresses pandemic preparedness. And I'll introduce that group just before their presentation. And then we'll have a discussion at the end really about sort of what we should be doing and what their ideas relative to the US ideas. So that's plan. Let me just quickly introduce Dr. Matthew Hepburn. He's a senior advisor to the Office of Science and Technology and Policy Director for Pandemic Preparedness in the White House Office of Science and Technology Policy. So, Dr. Hepburn, the floor is yours.
I want to confirm, can you hear me okay, David, just to make sure we're all systems
Yes.
Go? Super. Hey, good morning, good afternoon, everyone. Thanks for joining us today. My goal is not to be on the stage very long because we have an all-star cast and a very, very content-rich discussion that's going to address a number of these issues in pandemic preparedness. I want to start off with just a couple introductory remarks and talk a little bit about what we're trying to accomplish at the White House, especially in the Office of Science and Technology Policy. For starters, I think the types of people that do these webinars and that are on our panel, and I think we all recognize the enormity of the challenge in front of us and the seriousness of the situation of the current COVID pandemic, because it is not over, and as well as the future challenges that David highlighted. So I always feel like it's a bit of preaching to the choir when we bring these kind of things up, but it's an important part that we have to start there, that there has to be just a sense of resilience and a sense of resolve that we're not done, and the challenges are going to continue, so that we as a community, and I state that very broadly, domestic and global, but the community of experts and public health professionals and really all those that care about these issues, we need to be resolved, and we need to be constantly diligent, and that we have so much more to do. I do think that when we talk about these issues a lot, there's a sense of, well, we're trying, our community is really trying very hard, but no one's listening, and we get discouraged, and people care about other things, and there isn't enough resources and budget to make things happen. And as much as that's the case, I also have a lot of reasons for hope. Part of it is the kinds of conversations that we have today. There's just a lot of incredibly talented, smart, thoughtful people. And I do feel, especially in the academic and scientific communities, again, both domestic and global, that there's been a lot of trends that I think are very positive. The idea of sharing data and making data available as soon as it's ready, and certainly properly peer-reviewed and presented. But the concept that the international scientific community around COVID really rallied and said, we're going to research, publish, share, sometimes argue and deliberate and debate, but make things as public and transparent as possible, as well as expeditious, or responding to the crisis at hand. I love that trend, and I hope most would include. Well, there's certainly more that we can and should do in that space, but that's something very much worth highlighting, that we want to make that a norm for all future outbreaks. At the Office of Science and Technology Policy, where I sit now, the idea of transparency, of open data, open science, high quality science, but open data and open science is a top priority. So that's one of the things that really gives me hope. Another thing that gives me hope, I mean, our job is technology and innovation, and I think there's been extraordinary advances along many different lines of effort in terms of technology. The ability to be tested at home for COVID is a great example. And I oftentimes, those of you who listened to me before probably heard the story, but I always tell the story of a friend of mine with a 4-year-old, and 4-year-old had sniffles and a cough, and did a home test, and the home test was now negative. And the 4-year-old said, well, okay, I don't have COVID. What do I got? and what I tell that story because that's an expectation now that at least the American public has, that we can and should be able to diagnose at home for all sorts of infection. But that expectation, coupled by technology, I think opens up a tremendous number of opportunities. It's one of literally hundreds and hundreds of examples of scientific and technological progress that occurred out of necessity in the COVID pandemic. It doesn't mean we're done, but I do. Part of what we're trying to do at the White House level is to clearly identify the gaps and say we've got to work harder and do more in these certain areas, but also to say where we have made progress, making that progress permanent, if you will, and creating, if you will, not backsliding or going back to pre-pandemic levels in terms of science and technology and those different advancements that we've made. So with that in mind, with a spirit of resolve, but also with some cautious optimism, we've been working today. Wanted to highlight just a policy document called the American Pandemic Preparedness Plan that was generated out of our office in conjunction with tons of help across different departments and agencies in the federal government. The original plan was released a year ago, and so we had an annual report released in September. And I do encourage people to take a look at the document. I certainly want to hear what you think today and going forward. And my email is available. So we do these types of programs because we want to hear what people think and want to listen. And to take the lessons learned that we're going to discuss the rest of the time and incorporate that into good policy. Good policy shaped by experts like yourselves. What I will say is what I like about the progress report is that we made a very deliberate effort to say when we talk about the language of pandemic preparedness, people tend to necessarily gravitate to a few things, maybe in biomedical research with vaccines is a really good example. But what we tried to highlight is that preparing for future pandemics, at our best as a federal government requires all sorts of different aspects and expertise and programs and integration and all of that stuff. One of the examples that I can give, but I can give literally dozens, and the report gives literally dozens of these examples of, I'm actually very excited about manufacturing innovation and the ability to make medical products at the highest quality, but to be able to make those rapidly and at scale and distributed. I think all of that, the the technology's there, and now it's a matter of, if you will, institutionalizing that pattern. But what that does is that is all of that really enables us to have next generation products in a period of weeks to months, instead of years to decades. And it also allows it. So again, I highlight that as examples of technology where we're bringing in automation in the manufacturing process. And in my mind, that's pandemic preparedness. I'll make a final comment to highlight something in the report, and then I want to turn it over to our colleagues and really get a lot of dialogue on where we should be and what we should do. One of the things we do in the report is we talk about preparedness and obviously the challenges associated, but the concept of what the things that we're going to do in the response to the next pandemic are mostly those things that we as a community tend to do every day. And this is both for public health and our healthcare system and our manufacturing plants and our vaccine distribution centers and all of those different things that you can imagine where we're going to have innovation and technology for solutions. So then the premise is we basically have a fundamental choice. We can either say, okay, we're going to be prepared and we're going to tell you all the things that we need to do, and maybe we'll do some exercises and have a bunch of documents and stuff written down on paper, and we'll wait, and then when we get the call, we'll just be ready. Or, and I'm reflecting my bias, of course, or what we can say is things that we do to address other infectious diseases threats, contagious infectious diseases, can be thought of as pandemic preparedness. And I can give a couple examples, and that may be very obvious to the audience, but that's not necessarily how we tend to fund programs and sort of think about things in the federal government. We tend to divide programs, and we tend to have different stovepipes of if you work on this disease, then you can't use your funding to work on that disease. But in my mind, I'll use test to treat as a concept. I think for anyone who knows anything about healthcare, and certainly about how we treat infectious diseases, it's obviously a sooner the better. As soon as you can make a diagnosis and administer life-saving treatment, then the outcomes are going to improve. For COVID, we've really seen that play out with the ability to diagnose as rapidly as possible, and then for our highest risk populations, for them to receive either antibody or oral antiviral treatment. And the data, I think, is really strong in terms of the sooner the better, and that doesn't surprise us. That concept applies across infectious diseases space, certainly for sexually transmitted infections, certainly for bacterial infections, and the concept of making sure we have accurate diagnosis rapidly and the appropriate therapy administered immediately or as soon as possible is one of the core tenets of how we are trying to address antimicrobial resistance. And so as many other examples. So my point is this, is that our interest is improving, the government jargon word is capability, the capability to do test to treat, diagnose as rapidly as possible and administer life-saving treatment as rapidly as possible, and really track the implementation science so that continues to iterate and improve. And we aim to do that now for COVID. We'd like to be able to do that even more now for influenza. But the efforts that do that for sexually transmitted infections or antimicrobial resistance or a host of other infectious diseases that all of you could add to the list, the premise is that the better that we get at doing that as a system, the better then we are prepared for the next pandemic. And so we can give you dozens of other examples, but what I really like then is that if you agree with that premise, then it really does open it. First of all, it asks us to integrate much better than we have in the past, but it also says it gives us a chance to really go after health problems, especially infectious diseases problems that have been plaguing us for a really long time. And what gives me a lot of hope is the potential to vaccinate, to do better in vaccination, stated broadly, to eliminate vaccine preventable diseases, to do better in tests to treat, to make significant impact on endemic infectious diseases. And we can keep adding to the list. But that gives me a lot of hope. And really, and then when we tell people we have to prepare for the next pandemic, we can then couple that with the concept of, and oh, by the way, we're really eliminating or at least reducing global infectious diseases that are plaguing our populations right now. David, I'm happy to turn it over to you. And I know, again, this is going to be a great session with an incredibly robust and thoughtful discussion. Thank you.
Okay, thank you, Dr. Hepburn. That was a great overview of sort of the preparedness plan of the U.S. Let me quickly introduce the other two panelists. So we have Lauren Sauer, who's at the Global Center for Health Security as a scholar, and she's also an associate professor in the Department of Environmental, Agricultural, and Occupational Health at the University of Nebraska Medical Center College of Public Health. And notably, she's also an affiliate faculty at the BU Center for Emerging Infectious Disease. And then Dr. Diafuka Saila-Ngita is a research associate professor of global health at the Tufts University Cummings School of Veterinary Medicine. So welcome. And I guess maybe ladies first. Lauren, do you want to sort of start out? Do you have questions or comments?
Yeah, I'm happy to. I mean, I think that there are opportunities for really taking some of the things that Dr. Hepburn described and focusing on how we can engage at the community level, right? And I think everyone on this panel, but also everyone that has come together for this webinar has talked about the importance of community engagement in building our capability to do this equitably and our capability to recognize the populations that we're planning for in the plans themselves, right? And that is a challenge I think that we continue to struggle with, but I would love to hear, and I'm going to put Matt back on the spot. I would love to hear within the building blocks of AP3, how do we bring community into these plans from the get-go, right? Preparedness, I think, you know, I've worked in preparedness for a long time, and I think if we leave out the communities that have to implement the plans don't work. And then the cost of not being prepared goes up substantially on the communities that are affected themselves, but also global on our global population. And I'm curious to see how we can better implement community engagement at the very foundational stage of the building blocks of the plan.
Can I add a question that's very closely linked to this? That's one that sort of been haunting me, having watched, you know, the challenges of sort of a decentralized public health system in the United States. You know, so there's the community, but the next step up is really almost the municipal public health department, and then there may be a county, city for big urban areas, and state, and a lot of these sort of operate. You know, they make their own decisions, although they try and follow central guidance. And big challenge during COVID has been, you know, having adequate resources, but also communications, like trying to sort of take messages and guidance that they're receiving from the federal government and implement them, but often making their own decisions about how to do it. And I guess the question really is, you know, this is almost like not a broken system, but it's a little too decentralized and probably under supported. And what is sort of the thought about how to strengthen this? Because this system also has to work closely with and engage the community.
Yeah, so I love it. we can talk a lot about this one. So I want to make 2 points on the community engagement, Lauren part, and then maybe the public health system and decentralized to finish up. So 3 quick points, but you know, certainly rich discussion. So thing one is that this idea of community engagement, absolutely. And one of the answers to Lauren is we just have to resource it. We just have to. One of the things that we've been doing at the White House as we should, is try to think through priorities. And as our federal government can and should do, we should constantly be assessing this fundamental question. I say this all the time, is that your U.S. taxpayer dollars should not fund something that the private sector or philanthropy or somebody else is going to do anyway. That's a waste of money. And if you apply that litmus test to our government investment in pandemic preparedness, we do, and we are, and we're constantly reevaluating that type of question. For example, if there's a medical product like a vaccine and there's a strong commercial interest in that vaccine, then, the federal government shouldn't fund that anyway. That's duplicative. That's not a good use of taxpayer dollars. What I think is a really, really good use of taxpayer dollars is community engagement at the zip code level. And I don't think the private sector in various incarnations and permutations is going to fund that. Now, certainly partnering with philanthropy and other people interested in that public good would be great. We'd love to leverage those resources. But at the end of the day, I maintain that that's going to require public funding, whether it's the state or the local or the federal level or something else. And I don't have another way to get it done. And I don't think a computer can do community-based engagement. I think it requires people that live there, that are health educators. Where I think there is tremendous opportunity is that if those people who live in the zip code are enabled to do their job really, really well, then what they can do is they can educate on COVID vaccine boosters, but they can also educate on diabetes and other health problems. I think that's where there is tremendous opportunity. So then you answer the question of what should we be doing as a system to enable them? Well, we have to resource it, but you also want to enable them. And so then we can get into some really interesting conversations, not only about what tools would they need for health education, but also what's the best way to make impact in communities in terms of delivering health behaviors type messages. And that's where we can get into a lot of really important social science so that we're enabling that engagement. So in other words, what kind of things should we say or do? And the problem I think we have is that we don't kind of know that, or maybe people think they know it. And I read a lot of experts who say, here's what we should do, here's what we should do. And I think those should be very data-driven approaches. So the second part of answer to Lauren's question is that, we don't tend to resource the implementation science and the operational research that should go into kind of everything we do. And I would, in that category of buzzwords, we say implementation science, operational research, but I would also say user feedback. User feedback in terms of our medical product development. I think home diagnostics is a really, really, really good example, but in everything we do. And I think what we're trying to change is the paradigm of we're going to fund and partner to develop a technology, but we're not going to have the 10 to 20% of that budget go to the implementation science, the rollout, the user feedback, and the iterations that we would need to do for that intervention to be most effective. So that's the change that we're advocating for. I don't know if we've gotten there yet. But where you can be helpful here is that, if we're talking about research budgets, we have to include implementation science and operational research in research budgets. And we tend not to, it tends to kind of be always kind of lower on the list. And that's something that we really are, determined to change. So that's the answer to your questions, Lauren, and I think they're great. I think to David's point, just briefly on the decentralized public health system, is that I agree with you. I've had a chance to actually visit, I've tried to get out on the road and visit a bunch of state health departments and talked with both state and local health officials. And I will sort of, the caveat that I will add is that I think there's some amazing stuff that's going on at state health departments. And maybe they've always been doing great work in some of these areas, but I think the pandemic and the resources that came with it have really catalyzed it. I use one example. The state of Washington has it's called WA Notify, and it's a really good case notification, de-identified anonymized case notification system. Now we see about 19 states that have these different kind of notification systems. But it's really good. And a lot of the state of Washington program was developed with a partnership with the University of Washington Public Health and with the private sector. So they brought kind of at that, at the Seattle and state of Washington community level, had a strong emphasis on equity so that they were going to be able to reach everyone in their state. And had a great program. So my thing too is that where we see that, then we say, okay, how can we take a best practice in one state and make it adopted by all 50 states? And sometimes that may be a federal government top-down answer. Sometimes it may be just an organic, the federal government facilitates, highlights best practice, and then the states adopt it. Now that's harder. That takes more work because you got to talk to a lot of people. But sometimes these organic solutions that come from the bottom up are the best solutions. So, the centralized, decentralized debate will go on perpetually. I just wanted to highlight that in the decentralized, I've seen some amazing work, and it gives me a lot of hope.
Super, thank you very much. Dr. Saila-Ngita.
Yeah, thank you, Dr. Hammer, and thank you for inviting me, and also Dr. Hepburn for the report and the presentation. When I read the report, the first thing that came to me was the speech that President Bush gave at NIH November 1st, 2005, because I played that video to my students in my global health class. And they asked questions. And one of the questions they asked is that when they look at that video, President Bush talked about stockpiling masks and respirators. So what happens during COVID, if that was planned since 2005? And also they talk about the money. They look at a lot of billions of dollars President Bush was talking about in that speech, and they wonder if that money was really allocated. So my first question will be in terms of the evaluation of the situation based on what was experienced during the COVID, because I believe the next plans we have to learn from what happens globally and also nationally. So, but I didn't see much on that side in the report, reflecting a lot on how the plans, the strategies that were developed in 2005 that President Bush talked about, how you are capitalizing on that and how you are moving away or what you are doing with that. So I would like your comments on that. But the second thing, last week I was in Singapore attending the 7th World One Health Congress. And one thing that was really key during that meeting is that the role of the environment sector. Everybody believed that the environment sector was not well involved in whatever is being done to prevent pandemics. And that's why even the United Nations, they're talking about a quadripartite now. They used to talk about a tripartite, FAO, WHO, and OIE, the World Health Animal Organization. But now they have a quadripartite. They've added the UN environmental program as part of that process. And even they're talking about moving from the international health regulations to a new treaty. Probably they believe that things didn't work out well. And we know what brought the global health security agenda was failures of about 70% of countries were not ready in 2009 to implement the requirement for international health regulations. But the 30% that were characterized as meeting the standards didn't do well during the COVID. So maybe the way of evaluating progress was not appropriate at that time. So I would like also to know how you intend to evaluate the effort you are putting in place in this effort of AP3. Thank you.
Yeah, it's fantastic. So 2 parts to the question, but I love it. Yeah, very insightful. So let's talk about the President Bush speech in 2005 and sort of and kind of concepts of stockpiling. And I will say that when we look back in terms of biodefense and pandemic preparedness from then, I think there's a lot that we wish was done, and there's a lot. I think we should have a very balanced perspective about it and sort of say there are certain things that we really wish that there was more investment, wish that there was more progress prior to the pandemic, and that would have really helped us out. We should also, though, acknowledge that, starting in 2005, that there was a lot of very deliberate efforts in terms of pandemic preparedness that without which we would have been in real trouble. I'll give one example, but I think it's for another time in a really rich discussion. As I think you and us have most tracked, that we had really some landmark legislation in terms of the Pandemic and All Hazards Preparedness Act around I think it was around or a little bit maybe before that time. But some of the things that came out of that initial piece of legislation was to even, if you will, have a strategic national stockpile, to have resources that were developed, that were dedicated to having vaccines and having treatments available, and also personal protective equipment. But it was also to create an advanced development organization where we could partner with industry to develop biodefense products. And that was called BARDA, which is in Health and Human Services. And the work of BARDA was absolutely foundational for our COVID response. That BARDA was the go-to place where we partnered with private sector to develop products such as vaccines and monoclonal antibodies. And that foundation was the foundation for Operation Warp Speed and everything we did in terms of vaccine and treatment product development. What we've seen is that other countries, for example, in the European Union, didn't have an equivalent advanced development organization for biomedical research in their governments, and has created that. So the EU now has a HERA, which is really modeled after our BARDA. And in a lot of conversations, there was recognition that they wish they had something like that. So I make the point of that there was some really great work that was done in pandemic preparedness, although we do wish we had done a lot more. With the concept of stockpiles, it's a really tough. It's a tough issue because stockpiling products can get really expensive. And, we have stockpiles of anthrax vaccine. Do we need it? Yeah, probably we do. How many vaccines should we stockpile? I don't know. It's a really hard question. Is that expensive to stockpile those vaccines? It is. And do the vaccines expire? They do. And so not the hard part about stockpiles is not only do we need to stockpile against anticipated future threats, and it's hard to know what the future is, but we also, our products expire. And so it's something that you have to maintain. And, as the points that I was making previous in terms of the federal government and in terms of priorities, we do have to make priorities, and we have to make choices in terms of what is the best use of federal government resources. And so that process, that's why we're on the phone today. That's why we're going to have these types of discussions. The hard part in pandemic preparedness is we think it's a priority, obviously, but there's a lot of competing priorities in terms of big challenges that our nation faces. National security and defense is a priority. Social security is a priority. I mean, we can go on and on. Addressing climate change can and should be a top priority. So at some point we have to figure out in the setting of limited resources what we think is most important. My take on stockpiles, one of the ways that we could potentially do better, though, is through innovation. So the first being that making products that are shelf life stable for a really, really long time. So we just got to buy them once and then they don't expire. But also, to the extent that we can innovate in manufacturing, and I'm really glad you asked the question, because what I love about manufacturing innovation is this ability to rapidly scale. So in other words, if we can make, if we're really, really quick in terms of we need to make more of a vaccine, even if it's an existing vaccine, but it turns out we have 10 million doses in the stockpile, but we're going to need 100 million doses. If we can make that type of product at light speed, really fast, at the highest quality, highest safety, highest quality, then you don't need as much in the stockpile. You just have to make sure that you're ready to switch in terms of flexible manufacturing to achieve that at scale. That's where technology really helps us out. And that's my point of bringing in automation. And there's a lot we can kind of geek out on if people want to have a different conversation about manufacturing innovation. But that's one of the ways that I think we can solve this really challenging stockpile dilemma. And that's true for PPE and masks and diagnostics, as well as vaccines and therapeutics.
I'm gonna let Lauren go next. I think she has another question.
Sure. I just wanted to expand on that piece that you mentioned earlier around our sort of implementing partners at the local public health level. And I think a place where we don't see a lot of engagement well, maybe not a lot of engagement, but a place where we're missing probably a loud voice is in the healthcare as an implementing partner in the US, also really decentralized, challenging local legal and regulatory landscapes, and also our healthcare workforce is substantially decimated. And so I'm curious about the innovation and how we think about training and scaling up workforce back to healthcare, and so which will help build our preparedness focus in that space, but also in thinking about healthcare as the healthcare workforce as almost test subjects for some of that innovation that you were just describing. So how can we better engage the people who have to implement in real time with these novel solutions? I think we saw a challenge there in PPE as we were rapidly trying to fill the PPE gaps in early COVID. Some of the people that were a little bit left out of the conversation were the end users of the PPE, and they have great ideas around innovation, but aren't always thinking about them in that systematic implementation science way. They're more thinking about them in operational approaches to getting the work done and keeping everyone safe and protected. So just curious your thoughts on that.
Lauren, great question. Great question. And perplexing, this sort of gap, this traditional gap between public health and population health and the healthcare system. And if you take a step back and think about that strategically, that doesn't make any sense. Like it doesn't make any sense how our health departments are completely disconnected from the medical centers down the road. You know, and I know there are certainly exceptions to that, but for those have evolved into two different systems, and you know, really it's one system, and it's a continuum between that system of population and healthcare, and so it needs to be reformed and fixed. There's a lot of things that we have to do to sort of make that better, but from a strategic level, we need to make that better. Couple of things though, sort of where I think they do come together. But first of all, we'll make the point on this idea of when we talk about the user community for what we do, and where do we roll stuff out, and where do we get that type of user feedback? I think people immediately jump to people and patients and stuff, so home diagnostics, and roll that out to different communities and hear what they think. But we don't roll stuff out and beta test it in the healthcare community nearly as much as we should. And I think your point is extremely well taken there, and we need to do much better at it. And it's low-hanging fruit that we should take advantage of. PPE is an obvious example, but I'd say for our product development too, for diagnostics and treatments, monoclonal antibodies and stuff like that as example. User feedback and early rollout with the healthcare system is a really good idea. And that's true for both COVID, which we're all kind of framing this as a COVID conversation, but it's, you know, your comment really resonates when we talk about Ebola outbreaks too, as you know. So all points very, very well taken. What I'm excited about from an innovation standpoint, and again, I'm OSTP, so I'm going to bring this back to innovation, is this idea of how we bring health to people instead of people having to seek help. And this frame that we've seen, kind of the pandemic has accelerated a lot of that change that should have happened 50 years ago, or certainly 20 years ago, in terms of technology has afforded us to reach people where they are instead of making them access the healthcare system. And now we're starting to adopt, 20 or 30-year-old technology to actually do that, with telehealth being an obvious example, and home diagnostic testing, but there are dozens and dozens of others. And I think that's a good thing. I think we want to ride the wave on that technology. I think we want to make, hopefully what that technology doesn't do is make healthcare more expensive and help, you know, big corporations and companies make a ton of money off it. Like what I hope it does is that it actually makes healthcare more accessible and affordable, especially for people who need it most, right? And so what we have to do is we have to implement this technology. It goes back to your question and my point on implementation science, so that we understand how, you know, use telehealth as an example. How's it being used? Is it better outcomes? All of that. We're seeing some, I see some data on that. I think there's a paucity of data in terms of what we could collect in terms of the impact of a lot of those interventions. But it kind of forces the opportunity, and I'll finish on this, the opportunity is that it does force fundamental reform and change in both our public health and our healthcare systems. In other words, you can't just sit back in the clinic and expect everybody to come to you and not worry about this whole, you know, it really forces our healthcare system to reach people where they are, and it forces our health departments to reach people where they are. And then if we're really good, you and us, we actually do that. You know, that's a public health and healthcare both reaching out as a team and meeting people where they are.
So I'm gonna unfortunately have to cut us off here. This has been a fascinating discussion, but we need to move on to the second part of this symposium. I mean, I actually have a whole bunch more questions that I'd like to ask, but I'll have to hold back on those. And actually, you know, one thing we really haven't talked a lot about is prevention. This is much more preparedness, and so I think we'll probably get into that a little bit more in the second half. So thank you, Dr. Hepburn, and thank you to the two panelists. Let me just quickly introduce the next three speakers. So we have Dr. Linda Safe, who's a distinguished university professor at Ohio State University. She works at the Center for Food and Animal Health and the College of Veterinary Medicine, and she is the co-director of the Virus and Emerging Pathogens program at the Ohio State University Infectious Disease Institute. And then we have Dr. Gerald Keusch, who's a professor of medicine and global health at Boston University at the Schools of Medicine and Public Health. He is the associate director for the National Emerging Infectious Disease Laboratory and also a core faculty at CEID. And finally, Dr. Stanley Perlman, who's a distinguished professor at the University of Iowa in microbiology, immunology, and pediatrics. So I think we're going to start with a brief presentation, and then we can open up for a discussion with, with everybody. I think all the panelists, including Dr. Hepburn. Thank you.
Jerry, you're on mute.
Yeah. Okay, I just saw that. Sorry about that. I was just thanking Matt and the panel for the very enlightened conversation, and I think what we have to say will dovetail very nicely with that. So we are going to report on a publication that appeared in the Proceedings of the National Academy of Science of the USA in October by a group which was named the Independent Task Force on COVID-19 and Other Pandemic Origins, Prevention and Response. Next slide, please. So who are we? Well, we are 14 people from around the world. The three names that are bolded are myself, Linda, and Stanley, who will make this presentation on behalf of the whole task force. We have diverse expertise. There were 2 MDs, 3 MD PhDs, 4 DVM PhDs, 4 additional PhDs, and a Master in Public Health. And our disciplines include medicine, pediatrics, veterinary medicine, virology, epidemiology, wildlife biology, public health, ecology, broad range. And each of us brought a network of colleagues that we have been working with for decades. The next slide. A very brief history of where this perspective article in the PNS came from. How did this task force come together? Well, we were originally appointed at the end of 2020 by the chair of the Lancet COVID Commission, Jeffrey Sachs, as a task force to the commission to address the issues of the origins, the early spread of the virus and the pandemic, and to consider One Health solutions that could be applied. I won't go into any details, but we had conflicts with the commission about the autonomy of the work of an expert committee. And ultimately, we reformed as an independent task force towards the end of 2021. And that led to the invitation from the Proceedings of the National Academy to publish a perspectives article, which is the report of the work of this group of 14 people. What were our methods? We were very focused on a review of science, focusing clearly on peer-reviewed science appearing in the high-quality medical journals. We did not have the ability to visit Wuhan or China. And so what we were able to do was at a distance. So a major review of the literature, which was ongoing throughout the work of the task force. We interviewed a group of individuals with expertise who were on all sides of the issues of relevance. And most important, through the magic of Zoom, we were having weekly conversations among the task force members. With the diverse expertise that I mentioned, and an ongoing review of the scientific literature in real time, which was really important. And those were the methods. It was the scientific method without direct experimentation. The major objectives of the report were, in fact, to take a science-driven perspective on what we needed, what has happened in the past, and what do we need to do going forward, because COVID was simultaneously a great triumph, as Matt was talking about earlier, but also a tragedy. And the next slide. So the outline of our presentations is the following. Linda Safe will follow with a review of the lessons learned from prior zoonotic RNA virus outbreaks in humans and animals leading up to COVID-19 due to the SARS coronavirus 2. We'll follow with the contributions from virology with some emphasis on where new technology and innovation can take us, and Stanley Perlman will deliver those remarks. And then I will follow up at the end with a looking forward with our conclusions and a focus on what we have called smart surveillance and the One Health strategies that we have identified. And then at the end, as David said, there will be a discussion. So without any further ado, let me turn it over to Linda.
Thank you, Jerry. So I'm going to talk a lot about historic perspective here, and I'm going to talk about priority viral zoonotic RNA pathogens, the coronavirus host, reservoirs, and precedents for their zoonotic transmission and spillback into new animal reservoirs. So what we've seen is accelerated spillover of key zoonotic RNA virus as epidemics and pandemics in the past 25 years. This is important because 60 to 75% of new emerging human pathogens are zoonotic, and almost half of these are RNA viruses. And at the end, I'm also going to talk about needed investments for prevention, mitigation, and control with a One Health focus. Next, please. So this is the historical context for the past 25 years of the accelerated emergence and repeated zoonotic spillovers to humans of select RNA and one DNA virus, monkeypox. And the red font shows those that emerged and reemerged or continued with repeated spillovers. The circled blue font shows the emergence within the past 2 decades of 3 highly virulent human coronavirus, SARS, MERS, and SARS coronavirus 2. So some of the lessons that we've learned is that all etiologic agents evolved from ancestral animal viruses, all were zoonotically transmitted to humans. It can take decades to identify the spillover pathways to humans. And then finally, repeated spillovers, as is typical with influenza from animal, avian, or swine reservoirs. The pandemic came from a swine reservoir in 2009. And also outbreaks, continued outbreaks, reemergence are common. Example is monkeypox that appeared in the USA in 2003, the first outbreak outside of Africa where it's endemic. And this came in through infected prairie dogs. So this is a risk factor that's not highly regulated, import of exotic pets into different countries. And now we see we have essentially a pandemic of monkeypox. Next, please. So we know that coronavirus have spilled over into humans for several centuries by various intermediate, particularly rats, rodents, now birds, hosts, and an assortment of intermediate hosts, so reservoir and intermediate hosts. So if we look at the endemic coronavirus, 2 alpha coronavirus, 2 beta coronavirus, those spilled over into humans, those 4 in L63, 229E, OC43, and then HKU1 spilled over centuries ago. And for some of them, we still don't know the intermediate reservoir. So most of these were all from bats or rodents. Interestingly, the 229E OC43 spilled over from ungulates as the intermediate hosts, camels and cattle, because of a close association with these species during the domestication process. So next, please. We see now, recently, just in the past 2 decades, about 10 years apart, the rapid spillover and severe disease associated first with the SARS coronavirus, spillover from bats to civet cats to humans in southern China, 2003, the MERS coronavirus, continuing spillover from bats to camels to humans since 2012, and now the recent SARS coronavirus 2 pandemic, through a bat ancestral coronavirus. We don't know the intermediate host since 2009. Next, please. So what we can also see, there are several new zoonotic coronaviruses in these red rectangles that may be poised for human epidemics if they're able to mutate to acquire human-to-human transmission. So examples, these could all be examples of WHO disease X shown here on the end. That may be the cause of the next pandemic. That's not if, but when. So we have first the human porcine delta coronavirus. This was recognized in cases from 2014-15, spillover from birds to pigs, and then from pigs, human cases in children in Haiti. And these were recognized not in hospitals, but in school clinics. Then we have the SADS outbreak, continued spillover from bats to pigs. And this virus, severe acute diarrhea syndrome, killed many pigs in southern China. And this virus can infect human respiratory cells. And then more recently, reports of the first human pneumonia canine coronavirus spillover from dogs independently in Haitian people who did medical work in Haiti, and then also in hospitalized children with pneumonia in Malaysia. Next, please. So I'm going to use the example of swine coronavirus to show how in another host species, these coronavirus can continue to emerge, evolve, and cause devastating epidemics, not only in humans, but in animals. So because these are RNA virus, mutations, deletions, recombinations can generate porcine coronavirus with altered virulence, tissue tropism, and potential, as I mentioned, for porcine delta coronavirus for cross-species infections. So some of the lessons learned, next please. First of all, comparing an enteric strain, TGE, and a respiratory strain, porcine respiratory coronavirus, we know variants can arise. This happened by a large deletion in the spike. And that completely altered the tissue tropism from enteric to respiratory. The virus spread throughout the world, the respiratory strain by bioaerosols, much like SARS coronavirus 2. And we can see that some differences now emerging with some of the strains of SARS coronavirus 2, where the Omicron appears to have less tropism for the lower respiratory tract and mainly tropism for the upper respiratory tract. Next, please. We can see that new viruses in the red circle here with the bats can emerge from bats to cause a global pandemic, porcine epidemic diarrhea virus in swine that first appeared in Europe, and then the SARS virus in southern China. Next, please. We know that established viruses like PEDV can disappear largely in Europe after it emerged and circulated from the 70s to the 80s. Then it reappeared in Southeast Asia and China. A highly virulent strain appeared in 2010. And then in 2013, this virus spilled over to swine in the US. It killed 8 million baby pigs, or 10% of the US swine population. So these viruses are also a threat for food security. Next, please. And finally, now that we have the historic strains still circulating and newly emerged strains, PEDV, we see recombinants of these two viruses. So this raises concern whether we could get recombinants between SARS coronavirus 2 and any of the prior coronavirus or the endemic human coronaviruses. Next, please. So it's been in the news repeatedly that coronavirus can spill over from humans into many animal species. First, our pet animals. Second, the zoo animals, a large number of species of zoo animals, including non-human primates, baboons, gorillas. Then we've seen the spillover of into farm mink, looking for now vaccines for mink. And this is important because these also spill back to humans. And then reports in the US of infections in white-tailed deer. Next, please. So we were involved in this work surveying white-tailed deer in Ohio, but historically we have estimated 30 million white-tailed deer in the US. Could these be a reservoir host for COVID-19? And that's almost one deer for every 10 people. There's limited evidence right now for deer to human transmission, but this has not been thoroughly studied. The one case is from Canada. We do know deer are experimentally susceptible in 3 different studies to different isolates, the tiger zoo isolate, the original human lineage, and alpha coronavirus. So there's virus transmission to contacts, but no disease, so it's asymptomatic, and we get seroconversion. Next, please. So we did the study of deer in Ohio, and what we found is the prevalent strains in the deer, shown here highlighted in the color, were the same as the prevalent strains in humans, the B1.2, this blue, dark blue area, and the blue down here for the evidence of the transmission from humans to animals. We also found 2 other lineages that are depicted here, and the one in the greenish, we saw deer-to-deer transmission. So earlier it was found that at least 40% of US deer average in Midwest, also New York, had antibodies to SARS coronavirus 2. We found 33 to 36% RT-PCR RNA, viral RNA in Ohio and Iowa deer. We saw multiple human to deer spillovers and then spillover from deer to deer. And it's also been shown that the variants Delta and also Omicron in New York can infect deer. Next, please. So the question is, how did deer acquire SARS coronavirus 2 from humans? Will it persist and adapt in deer? Will deer transmit the virus back to humans or other wildlife or grazing ruminants, sheep, cattle, goats, even alpacas? So we need a One Health approach to monitor cervids, other animals, and the ecology globally. Next, please. So this just summarized the animals that are, some of the animals that are susceptible. There are at least 80 or 31 species that are now highly or moderately susceptible by natural infection or experimental infection. Next, please. So some of the lessons we've learned with One Health implications, SARS coronavirus 2 has a broad host range, pets, zoo animals, mustelids, wildlife. They're mostly subclinical, except for farm mink who have a syndrome and also deaths similar to COVID-19 in humans. Also some infection and mild disease in cats. And the more disconcerting aspect is that there's now two-way spillover of some of these strains. So spillover from humans to the animal and the animal back to humans. This is from the red arrows here from cats, white-tailed deer, farm mink, many cases in the Netherlands and Denmark, forcing them to cull most of their farm mink in that area, and even spillover from hamsters in Hong Kong, but the pathways are all unclear. So again, the concern is, will we have a wildlife reservoir where the virus can persist, adapt, and mutate, and then transmit new variants that are resistant to antivirals or disease or vaccines back to humans? Next, please. So we need investments for preventing these viral pandemics with a One Health focus. And this is all summarized in our PNAS paper: smart surveillance, risk assessment, interventions, identifying hotspots. Many are in lower middle income countries with less infrastructure or diagnostic capabilities. We need to survey animals, humans, the environment, prioritize animals at the wildlife, domestic animal, human interface, especially the farmed wildlife, wildlife markets, airborne or wastewater. Environmental DNA monitoring can be used to confirm the species present. We need to stop zoonotic infections by animal virus by syndromic or asymptomatic surveillance for antibodies. Especially, we need to focus on clusters of unknown etiology of respiratory enteric infections in outpatient clinics, like we saw for porcine Delta coronavirus spillover to humans, symptomatic hospitalized cases with pneumonia, like we saw with canine coronavirus, and the immunocompromised. We need to survey the environment, wastewater, sewage, bioaerosols for both humans and animals. Next, please. We need to develop new diagnostic tools for the above field surveillance and multiple sample types from animals, humans, the environment. Broad virologic assays, multiplex serologic tests that need to be developed. We need to use risk assessment so we can develop mitigation. And there are new risk assessment tools such as the influenza risk assessment tool for influenza, the likelihood for spillover and severe disease. We can now start applying artificial intelligence, machine learning to virus and risk prediction. Next, please. And then we still need better preparedness and prevention in terms of broad spectrum vaccines, pan-coronavirus, pan-influenza, human vaccines, but we may also need animal vaccines, with the rabies as an example, to prevent new animal host reservoirs and spill back to humans. Interagency collaboration, global, regional, national collaboration, coordination with biobanks, databases for data analytics. A good example here are the national, regional WHO networks for influenza, but they also should be developed for other major spillover viruses. Funding, we need sustained funding to support integrated collaborative research on zoonotic diseases, focusing on not just humans, but also animals and the environment. And we now know that pandemic preparedness and response programs are an integral part of national security plans. And this is important from the whole concept that now we think the estimate for the economic impact, not to mention the human impact, is at least $16 trillion. So I think the analogy here is an ounce of prevention is worth a pound of cure. And last, please. So we need this One Health focus to control zoonotic diseases. And this includes combined efforts, veterinary, medical, environmental, social, cross-disciplinary scientists, and global interagency collaboration. So I thank you.
Okay, so I'm going to follow up on what Linda started, and I'm going to talk about virology, the new technologies and innovations, and some ideas. So I wanted to start by just mentioning some of the progress that was really done as a result of the pandemic. We developed molecular assays to develop nucleic acids. This is the PCR tests that have been used widely. We developed tools to detect viral antigens, and this was a mixed progress. initially, there was many tests on the that could be obtained. They had inadequate sensitivity and specificity, but they improved as the pandemic progressed. And we've all learned that this is really an important thing to do. Vaccines and antiviral therapies were developed, and that was really done very well during the pandemic. We learned more about how SARS-CoV-2 caused disease and deaths. This was from research efforts, and we still need more information about this because there's still much that's not known. And a lot of this research was really contingent on previous studies that the scientific community had done on SARS-CoV and MERS-CoV, and several, as Linda mentioned, several reagents such as pan-coronavirus vaccine primers for RT-PCR studies for diagnosis in animal models, and RNA vaccines, as well as antivirals, had been developed for these other viruses. So investing in science, even without having a disease that caused a huge economic or social impact, was really critical for when the pandemic occurred. And this just also pointed out that working on pathogens that cause no or less widespread human disease is actually beneficial in the long term. So what some of the gaps that I think we saw during the pandemic, as I mentioned, we developed new methods. And I mentioned also that the antigen test was initially erratic, but it became more useful, specific, and sensitive. And I think that the antigen detection has really taught us something, because we realized that RNA assays were so sensitive that people were being diagnosed as having COVID or not SARS-CoV-2 infection way past the time when they were either contagious or really sick. So the antigen in some ways was a compromise because it wasn't as sensitive, and it tended to disappear more quickly as well because of that, as compared to the RNA assays. So it actually gave us more information about who might be contagious. And for smart surveillance, one would like to both antigen and detection and viral RNA detection methods to be as sensitive as possible, because of course during surveillance we're not as interested in contagiousness. We want to know what's out there. So this would be important for us to have. And one would also like to have broad panels of antigens to identify antibodies. And I think there's been some progress made in this, but more can be made. So some of the gaps that we have is one of the things that we think is really important. Pathogens cross over to human, cross species from in many places in the world, but certainly parts of Asia are really hotspots. So these places often tend to have limited resources. So developing good point of care methods for pathogen diagnosis when people are sick and would be very useful in times of outbreaks. In the absence of human disease or of outbreaks, then we may not need to have improved diagnostic tests for points of care methods, but of course that would be great if we did. But even if we had them in local or national laboratories, that might be sufficient. We want to develop tools to develop infectious virus in the field. Right now, infectious virus can only be detected in the laboratory. If there was a way to do that in the field, that would be helpful. And we also obviously want to minimize lab worker exposure, whether in the field or the laboratory. A second goal is to develop methods for serological screening of blood samples from wildlife as well as humans for a broad range of pathogens in areas of high spillover. And I think a goal that's being partly reached, but we could do more work on, and I think we could help with, is establishing national laboratories in countries with limited resources but high risk of cross-species transmission of viruses or other pathogens. And this is all based on determining which pathogens are likely to cause human disease. So surveillance may give us lots of possibilities, but we want to use the laboratory and our existing scientific knowledge to focus on the ones that are most important, because so many could be identified. And so some other things that we think are important are, as new pathogens are identified, to facilitate exchanging this information with health providers, governments, NGOs. I think we talked about that a little earlier in this webinar. And this is so that diagnostic tools, vaccines, and antiviral therapies can be developed efficiently. And again, the more we know about the actual pathogens and the human responses to these viruses, whether it be immunological or otherwise, the better we'll be able to devise vaccines and therapies. And we need to work carefully with national laboratories to make sure appropriate procedures are followed, and the CDC has done this well in the past. And then we want to help resource poor countries develop biobanks for coronaviruses, as well as other viruses of unknown importance, as well as some of the samples that I talked about already. So I think this is now on to Jerry.
Thanks, Stanley. So let me give a summary of the excellent presentations that Linda and Stanley have provided. So the PNAS paper came to a couple of conclusions. First, that the rate of emergence of pathogens and these RNA viruses in particular is accelerating. But history also shows that we fail to heed lessons from past emerging infectious diseases. They arise, they may disappear, like SARS, and initiatives in science that are taken and funded lose their funding and they disappear. Among the emerging pathogens, RNA viruses, because of the nature of RNA and its propensity for errors and recombination, as has been described, these are of particular concern for epidemic and potentially pandemic emergence. And as both Linda and Stanley have mentioned, what we need to do is to have an integrated and implemented One Health strategy. Next slide. We had 5 categories of recommendations. The first is smart surveillance that both Linda and Stanley referred to. There are a few people out there who have been talking about risky research. The famous phrase from one of them is, if you go out looking for dangerous viruses, you will find them, with the implication that that will result in a release to the human population. Well, in fact, what is of the greatest risk is being blind to what's out there and not knowing. Surveillance is absolutely essential, which has been very well documented with influenza. And we know how to do this well, safe, and secure, in contrast to the large numbers of people, for example, tourism to bat caves, where some of these epidemic viruses have emerged, uncontrolled, no precautions, and numbering in the tens and hundreds of thousands of people a year, plus the communities living in proximity to these bat roosts, compared to this relatively small number of well-trained scientists who are doing surveillance. We absolutely need increased investment in preparedness, basic and translational research. We have the opportunity to reduce the drivers for spillover and spread, which has the potential to prevent an emergence from occurring. But on top of that, as COVID has so clearly demonstrated, we need to counter misinformation and disinformation. And this rises to real importance when we see what's happened in this country over the course of the epidemic. And ultimately, we need to strengthen One Health governance and science as a global initiative with true partnerships. Next slide, please. So emerging zoonotic infectious diseases present a number of options for prevention. In the background, these viruses, the RNA viruses, as Linda and Stanley have both discussed, ancestral strains are in various animals, bats, rodents, occasionally non-human primates, others. Some of them ultimately can infect vectors that have the potential to transmit them to other species. And this kind of spillover from the ancestral virus into the animal population in the wild is going on all the time. And that presents the potential of spillover to species that might ultimately come into contact with humans, and domestic animals, and an amplification process, as Linda has discussed, is one of those. But at times, these also spill over from the animal reservoirs in the wild into humans. And when there's efficient human-to-human transmission, we get now an outbreak of human disease. Next, Stanley. That means that there are a number of places where we can intervene. On the left, by knowing what's happening out in nature, we can forecast what might be coming, and we might be able to improve our readiness. With the appropriate tools, we may have early detection before it or early in the course of an outbreak in animals. We might be able to implement control measures which would prevent its spread into humans, which is in the darker green. And when that is happening in the human population, we might have a rapid response because we know about it that would bring that outbreak to a halt before it reaches a pandemic. And by doing this, we have control benefits for animals, and we have control benefits for people. Next. Let's scroll through to the next slide. Let me go back to the smart surveillance. There are 6 components and tools that are relevant. First, targeting, which has been mentioned by both Linda and Stanley. We can focus on unusual clusters of cases in animals or humans. We can look at most likely animal reservoir hosts. We can focus on humans who live at high-risk zoonotic spillover interfaces, high-risk activities, and emerging disease hotspots. This saves money and targets the efforts. Next. We need better methods for pathogen detection early on. Next. Antibody detection, as Stanley mentioned. Next. Novel strategies, which Linda mentioned, wastewater, bioaerosol, other novel sampling methods, strategies that can be applied in the field. Next. Information management and sharing. We need innovative information technology and artificial intelligence tools to deal with this massive data information. And next. And then a risk assessment. How likely a pathogen is to be virulent and how likely it is to cause a serious outbreak. Next. There are some complementary concepts that go along with this. Continuous quality improvement in biosafety and biosecurity is integral to component of smart surveillance, pandemic prevention, and response, without question. We need a rapid coordinated global response. We need sustainable mechanisms and financial resources in place. Next. We need to be able to counter political interference and clarify the limitation on the autonomy of science to operate as scientists. And that's a science policy issue of real importance, supporting an independent science enterprise and the scientists who do it. Next. We need to affirm the validity of the scientific method, a self-correcting method of investigation. We have to absolutely differentiate what is real science from speculation, not only in our literature, but in our policy responses as well. And next, we need to have consistent, informed messaging based on evidence available to the public before and during, especially during an outbreak. And finally, we need methods and mechanisms to support and protect scientists from threats, trolling, and attacks. And only in this way will we really be able to move forward in doing better, of magnifying the triumphs in the next outbreak and limiting the tragedies that result from failure to address all of these issues. So thank you, and I think we're open to questions from first from Matt, and then from anybody in our other panel and the audience.
So, Dr. Hepburn, do you have any comments or questions?
No comments or questions. I know we only have a few minutes left. I'd love for if there's a couple from the audience that we can kind of get in to make the process participatory would be sort of my preference. That was certainly a tour de force though of covering a massive amount of topics. So there's probably 30 different topics that are seminars in and of themselves. But yeah, but I loved it. Thanks.
Right. For the audience, we have a relatively small audience, so maybe you're welcome to put questions in the Q&A. But right now there are no specific questions. But I mean, I'm actually happy to lead with one. And this really is. I mean, you've touched on this. I mean, Dr. Perlman and Dr. Keusch. I mean, the issue of diagnostics and the challenge is, like, I've actually looked. I run a surveillance network called GeoSentinel. And we looked back at our data for January, February 2020, and it turns out we had a bunch of people that had traveled from China into different countries in Europe and the US that had an ILI that could not be identified. And the challenge is when you've got something new arising is we have no way to diagnose it until it's really identified, and then there has to be a very rapid scale up of diagnostics. And I mean, I do feel like the U.S. stumbled a little bit in the beginning with CDC trying to sort of maintain control over quality and disseminate the sort of diagnostics, which they had done with Zika, and that also started out badly. And I think we need to learn from these lessons to be able to both identify a pathogen quickly, but get diagnostics out there quickly. And using PCR is just a matter really of sharing, some of the PCR primers to be able to rapidly scale those up, because there's so many labs now that can do PCR. Anyways, I just wonder what your thoughts on how to address this challenge are.
Well, I would agree with what you say. I think the other thing that I learned from 2020 is that actually assays had been developed in the rest of the world. So if we had been paying a little more attention to those assays, because the folks in Germany had developed great assays for the MERS-CoV, that still use those assays used worldwide, and particularly on the Arabian Peninsula, where all the cases are occurring. So they very quickly had primers and antigen tests for SARS-CoV-2. So being open to methods available elsewhere in the world would be a help. Now, that if this is an outbreak that occurs in the US, of course, that wouldn't be true. But we also have, because we've identified so many virus families already, we have information about many, I don't want to say all, because you never can really say all, but a huge number of the possibilities. And some of them, even coronaviruses, which were not so intensely studied before 2020, we knew which regions of the virus might be consistent or invariant between different strains. So we knew how to develop primers. So I think that by having this information across many virus classes, what are the most invariant regions, can we make primers to them? That would be a first start. And then, of course, scaling it up, companies can do that pretty quickly now. So I think that there are ways to do this well. And then getting it out of this country into places with low resources, of course, as we all mentioned, is really critical to stopping any pandemic.
I'd like to back up a little bit before those diagnostics are made and available, to point out that the awareness of this outbreak began with clinicians in Wuhan in about the third week of December 2019. And they were seeing cases presenting with severe pneumonia and a real cluster. And two separate groups of clinicians in two different hospitals, when they used the available diagnostics and came up with nothing for other viral diseases, they each sent samples of lung lavage to genomic companies in Wuhan, and very quickly got back enough sequence information to indicate there was a novel coronavirus circulating and was the likely cause of this. In the beginning of January 2020, several laboratories in China actually got full sequence. And on January 5th, one of them sent the sequence to GenBank. And 5 days later or so, released that sequence directly on the blog virological.org. So in record time, clinicians using next-gen sequencing, realizing that next-gen sequencing could help, came up with a diagnosis with the likely agent. It was fully sequenced. The sequence was released, and countries then were able to develop the PCRs that Stanley was talking about. This kind of global collaboration is what we need to be emphasizing into the future, and that, Matt, that's where the broader policy issues surrounding the technology really comes into play. How do we share effectively? Pandemics are by definition global, and if we don't work together collaboratively and positively as scientists, we're going to be left in the dark, and instead of the triumphs, we'll have the tragedies of the next pandemic.
So that was a great sort of segue into the question, which is essentially your question, but it's from Andrew Ellis, which is, I was wondering your thoughts on global cooperation. Are the current systems of sharing surveillance information adequate? What organizations are best sort of positioned to address this? And I guess, I'm sort of curious to hear Matt's thoughts on this.
More than curious, I think it would be great.
Am I off mute? Can you hear me okay?
Yeah.
Yes.
Super. Okay. I got the dual mute thing going there. Yeah, I think the hard part, David, is the price tag. And it really goes back to the points that I was making earlier. And I think we need to tie that in, that this is a priority exercise, and we have to say what I really like about the smart surveillance and sentinel surveillance points, coupled with affordable diagnostics, as best we can do cheap testing or batch testing or all of those types of solutions, and that's going to allow us to reach out. But we're not going to be able to spend $100 billion a year on testing everything for everywhere and every pathogen and sequence the world and all that other stuff. It's not going to happen, and it's so the challenge for us collectively is to pick where we're going to have the most impact.
Linda?
Yeah, just a comment. So I think what's lacking is this global coordination. So I think the best example that I've seen for now are the WHO reference labs, which are both national and regional. And we do have those in the US. And coordination then with the quadripartite that Dr. Diafuka mentioned, the animals, the FAO, OIE, wildlife, and the WHO, and then with the national, like CDC organizations, but also not just CDC, but agriculture in terms of animal health components. So this whole One Health picture, I think, needs to be in the mix.
Just to add to it, I think this is an issue of leadership seizing the moment. It comes down to champions and leadership and willingness to focus on real information and how can we best share it. And what was proven so early in this outbreak, in January, this was disseminated from Wuhan, China, throughout the entire country of China as the perfecta, the perfect storm. It was the holiday season when people were traveling all throughout that country. And by the end of January, the virus was known to be in 18 different countries and spreading very rapidly. This is global. If we have ongoing failures of global leadership and willingness to collaborate, involving the leadership in science and in the enabling environment that allows science to be translated into policies and implementation, then we will surely repeat a tragedy of another COVID-19. It's a challenge. We didn't have any magic bullet to say how the governance might work. We just could realize that what's been done in the past has proven to be inadequate, and we need to be working very hard at a global scale to make the necessary changes.
Well, that was a great sort of final comment. I think we've run up against the clock and we're out of time, but thank you. I mean, thanks to all the speakers and the panelists. This has been a really interesting discussion, and I think we'll need to continue it in some format because there are more challenges ahead in the pandemic world, I think. So thank you all, and have a good afternoon. Take care.
Thank you.
Bye-bye.
Thanks.